Good evening, distinguished guests, and everyone present here today. It's a real pleasure to welcome you all for this scientific webinar. I, Ritika Jaiswal, representing Concord Biotech, takes the privilege to welcome you all for this insightful academic session. Concord Biotech, the global biotechnology and immunosuppressant leader, is committed to deliver innovative products in the therapy of rheumatology, transplant, nephrology, and immunology, enhancing the patient quality of life. Concord Biotech is really honored to host this session today. And now I like to take a moment to introduce our distinguished speakers today who will share their valuable insights and expertise with us today. Now, let me take the privilege to introduce all our eminent speakers. I welcome Dr. Kriti Kishore. Welcome, ma'am.
Thank you.
She is a consultant rheumatologist at Yatharth Hospital, Noida. Welcome, ma'am. Then our next speaker for today is Dr. Sahil Garg. Welcome, sir. A warm welcome from Concord Biotech.
Thank you.
Welcome, sir. Dr. Sahil is a consultant nephrologist and he's based at Amritdhara Hospital, Karnal, Haryana. Very warm welcome to you, sir.
Thank you.
Then our next speaker we would like to honor is Dr. Ankit Agarwal.
Yeah, thank you.
Welcome, sir.
Thank you.
Dr. Ankit Agarwal, he's a consultant gastroenterologist and he is based at Vardhan Gastro Clinics from Jodhpur, Rajasthan. So it's a real pleasure for Concord Biotech that we are having such eminent speakers with us. And now we'll just take forward the session. The topics of discussion for today are basically two. Topic one is lupus nephritis, where our speakers, they are going to provide us valuable insights about the diagnosis, treatment, and basically the role of MMF and tacrolimus in new and refractory patients. And the second topic of discussion is adalimumab in IBD and the IBD associated arthritis, where we'll be having a very insightful discussion. So not taking much of your times, let me just hand over the session to Dr. Kriti Kishore. Yeah, ma'am. Ma'am, you can continue.
Thank you, Ritika, for the introduction and for giving the opportunity to talk on two very important topics, and that too an interspecialty talk. I'll start the first topic first. So I'll be discussing the various aspects of management of lupus nephritis with Dr. Sahil, and we'll go one by one with the various questions. Dr. Sahil, if I may ask you, like regarding the diagnosis of lupus nephritis, Ritika, can you please move to the first slide?
It's not moving.
Just 1 minute, ma'am. Just 1 minute.
Yeah. So by the time Ritika is arranging the slide, Dr. Sahil, so what, since this seminar is mainly aimed at physicians, so what would you like to tell about the diagnosis of lupus nephritis in a patient of SLE? When to suspect and how to diagnose?
So the diagnosis depends on the various factors, like on the if there is a unexplained rise in creatinine of a patient of lupus SLE, or if there is any kind of edema clinically, like sign, there are symptoms and there are signs. So symptoms can be edema could be there, and decrease in urine output, or rise in blood pressure readings, and signs could be raised blood pressures, and investigation wise it would be hematuria or blood in urine and proteinuria. So these are the things that we have to keep in mind if a patient of SLE comes to us, and it has to be repeated like 3 months to 6 monthly in patients having SLE.
Uh, so is there a particular level of proteinuria that you aim before deciding whether to biopsy or whether to suspect lupus nephritis?
So yeah, so there are some criterias according to the ACR. So if a patient has proteinuria of more than 500 milligram per gram of creatinine, then definitely the patient has to undergo a renal biopsy. Or if the proteinuria is less than 500 milligram along with active sediment, that is blood in urine or hematuria, then also the patient has to undergo a renal biopsy for the
Oh,
correct characterization of the lesion.
okay. Ritika, can you move to the next question, please? So as you were already discussing the role of renal biopsy. So are there any instances in which renal biopsy might also be required?
So yeah, so if a patient is not responding to the treatment, or there is a sudden rise in creatinine from the baseline level, or we are suspecting that or we have to decide for the second line therapies, or if a patient has increase in creatinine and we think that the patient has some chronic changes on the biopsy, and we have to decide for the any elevation in the or escalation of the treatment, then patient has to undergo a re-renal biopsy. So there are three four indications in which we have to do a re-renal biopsy in SLE patients.
Okay, as very rightly said by Dr. Sahil, like a proteinuria of more than 500 or presence of active sediments in the urine in a patient of SLE or clinical signs and symptoms of renal involvement such as hypertension, presence of pedal edema, or any other cause of raised creatinine also needs to be ruled out. So these are the few indications of renal biopsy. We'll move on to the management part now. So uh, so, as I think most physicians are aware that there are various treatment options available for treatment of proliferative nephritis. And here mainly we will be discussing the management of class 3, class 4, and class 5 nephritis. So, I would like to ask Dr. Sahil, like, given a choice between mycophenolate and cyclophosphamide, what is your preference for induction therapy in class 3 and class 4 nephritis? And what are the dosages that you prefer, and whether or not you prefer a Euro-lupus protocol over a NIH protocol in Indian patients?
So very rightly said. So there is a debate over cyclophosphamide versus mycophenolate. So in the recent trials and recent consensus, see the Western world data is moving towards low doses of immunosuppression in these patients. So totally in the ACR to 2024 guidelines, so they are not suggesting any role of NIH protocol, as the risk of infertility and cancer is on the higher side as compared to the Euro lupus. So in patients, so I would prefer the Euro lupus as compared to the NIH protocol first. Then moving to the next question, that is either cyclophosphamide versus mycophenolate. So if so according so there is no not a definite criteria that we have to use cyclophosphamide or mycophenolate. So it depends on the individual to individual. So if a patient has proliferative nephritis, or he or she is dialysis dependent, or dialysis requiring, so I would definitely prefer low dose cyclophosphamide, that is the Euro-lupus protocol, as compared to mycophenolate in the induction phase. That is the 500 milligram fortnightly for 6 doses. Then I will definitely shift her to the on maintenance to the mycophenolate. While if a patient has uh, not dialysis requiring, or she wants to preserve her fertility and wants to have children in future, so in those patients I would definitely prefer mycophenolate. So I will be starting her on the lower doses. So according to the body surface area, that dose requirement is almost like 1 to 1.2 gram per meter square. So the maximum dose I will be moving will be 1.5 gram to 2 gram BD in these patients. but I have to keep a check on the side effects like the diarrhea and the myelosuppression that can happen in these patients. So yeah, so for patients who are dialysis requiring, I would be preferring urolupus, and then for those patients who are not dialysis requiring, I would prefer mycophenolate induction.
Okay, thank you, Dr. Sahil, for the clarification. And I think this is for the physician. So you have both the options of both cyclophosphamide and mycophenolate in Indian patients of biopsy-proven class 3 or class 4 nephritis. And sometimes even when these patients fail to respond to urolupus, if there is no availability of other therapies like belimumab or tacrolimus or rituximab, in those cases you might actually switch these patients to NIH therapy also if they are not responding to the urolupus protocol. But as rightly said by Dr. Sahil, if we compare mycophenolate and cyclophosphamide, the adverse events definitely including infections and infertility issues are higher with cyclophosphamide, and also also the potential to cause malignancies in the future. So usually a dose that is preferred for induction is around 2 to 3 grams, depending upon the tolerability, that is the GI side effects. And in maintenance, it is usually 1 to 2 grams, depending upon the proteinuria levels. So next question, Ritika. So I think this part we have already discussed, the dosing of mycophenolate in induction and maintenance. So Dr. Sahil, as you are a nephrologist, I would just like to ask, in lupus patients who undergo transplant, is there any difference in the dosing for mycophenolate, or it remains same, not as an induction or a maintenance, but usual doses for transplant patients?
So in transplant patient, we usually generally start from the 1 gram BD dosing. So we generally prefer, as the patient is already on tacrolimus and Visolon also. So the maximum dose that we use is 1 gram twice a day. That is a cumulative dose of 2 gram per day. But since there is less availability or scarcity of area under curve for the mycophenolate, so we exactly don't know the right doses for those patients also. So I think the doses are similar in lupus and transplant patient, but in lupus patient, the doses are slightly on the higher side, like 1.5 gram twice a day. So cumulative dose will be 3 gram per day.
Yes, and I think there are newer studies which are targeting the mycophenolate drug levels in patients of lupus nephritis, and they have found that patients who have a higher serum concentrations have lesser relapses over time when measured over a period of 24 to 48 weeks. So I think we'll need more Indian data on patients on MMF to see whether or not in future we need to monitor drug levels as we do with tacrolimus. Ritika, next question, please. So I think for the physicians, I think there's a newer 2024 treatment guidelines on lupus nephritis, which is the ACR ULR 2024 treatment guidelines. So according to these guidelines, the induction regimen for class 3 and class 4 nephritis is now triple therapy, which is IV glucocorticoids followed by oral glucocorticoids in combination with either mycophenolate or tacrolimus, or a combination therapy with mycophenolate, belimumab, and steroids, or a triple therapy with belimumab, ELNT, cyclo, and steroids. And this has been preferred by the ACR and ULR over the dual therapy, which we usually follow in Indian patients, which is induction with either cyclo or with mycophenolate. So have you ever given or any experience with using the triple therapy in patients of lupus as a first line therapy?
So I don't have any experience with the triple drug therapy. So we generally prefer the low dose IV steroids for along with the mycophenolate. So I haven't used both triple therapy in any patient till date.
Yes,
So,
and I yeah.
but it will be interesting to use tacrolimus in those patients having proteinuria, as the tacrolimus along with the immunomodulatory effect has anti-proteinuria effect also.
Yes, I think very rightly said. And another thing to look at in Indian patients would be the higher risk of infections. The data is mostly from European and North American patients. And I think the risk of infection, even with the dual therapy amongst Indian patients, is very high. So I think that would have to be weighed against the benefit of triple therapy in these patients. And I think going forward, it would be interesting to use this regimen as a first line instead of dual therapy in patients of lupus nephritis. Ritika, next question, please. So have you ever used tacrolimus alone for induction or for maintenance therapy in lupus nephritis without using mycophenolate or any other immunosuppression?
So no, so I haven't used tacrolimus alone as a maintenance therapy in lupus nephritis patients. So this has come in the ACR guidelines only recently that they are using it as a triple therapy. But since today we haven't used tacrolimus alone as a induction or maintenance therapy in lupus nephritis patients.
Yes, and I think there's some data from China, certain open label trials in which they have tried given tacrolimus along with oral glucocorticoids in patients of class 3 and 4. And they have found it to be similar to MMF at least. They haven't compared it with cyclophosphamide, but in at least Chinese patients, the PRR and the CRR response rates, which are the renal response rates, with tacrolimus is similar, but I don't think even I have used tacrolimus ever alone as an induction or maintenance therapy in lupus nephritis. Next question, please, Ritika. So coming to the management of class 5 lupus nephritis. So your experience of using mycophenolate, tacrolimus and other drugs in patients of class 5 lupus nephritis.
So yeah, so we have used MPA as well as tacrolimus in class 5 lupus nephritis patients. So in the ACR guidelines, they have also advised the triple drug therapy in class 5 patient. But in our general practice, we generally prefer steroids followed by the mycophenolate. And if patient doesn't respond to the mycophenolate, we generally switch that patient from mycophenolate to the tacrolimus level. But I haven't used both the drugs together in class 5 lupus also. So it's a new thing that we can try in these patients, as the MPA will have the immunomodulatory effect and the tacrolimus will have an anti-proteinuric effect, and we can taper down the steroids very quickly in these patients to prevent them from any steroidal side effects.
Okay. And in general, have you found that patients of class 5 lupus nephritis, do they respond equally well to immunosuppression as compared to class 3 and class 4? Or have you found that them to be more refractory to immunosuppression per se over follow-up?
So I think more than the immunomodulatory effect, they need better or the standard anti-proteinuric therapy, because these patients generally are proteinuric more as compared to the proliferation. So I think we are not using these drugs properly in the class 5 lupus, as the data on class 5 is less, and the proportion of class 3 and class 4 lupus, or class 3 or class 4 lupus with class 5, is more as compared to class 5 lupus nephritis alone. So I think the class 5 patients should be treated as a nephrotic syndrome directly. So we can start with the steroids, and then we can either switch them to either tacrolimus first followed by or mycophenolate. So my preference would be tacrolimus more than the mycophenolate or acid and its derivatives.
I think very rightly said that the main aim in class 5 lupus nephritis is actually not achieving the remission. It is the reduction of proteinuria, which is more important as compared to immunosuppression. And I think along with your take on use of empagliflozin or dapagliflozin in these patients, have you ever used it for the antiproteinuric effect?
Yes. So there was a study which was conducted in PJ itself. So they have used SGLT2 inhibitors in every class of lupus nephritis, and they have found a significant difference in proteinuria. So I think there is a stage use of these therapies. So first we will be starting with the ACE inhibitors, followed by the SGLT2 inhibitors, that is the dapagliflozin or the empagliflozin. And now studies may come on non-steroidal MRS, that is the Finrinon, also regarding the anti-proteinuria effect in these in lupus patients, or in general glomerulonephritis patients.
Okay. Ritika, next question, please. So, I think we have already discussed in depth about role of tacrolimus as an antiproteinuric measure. Just adding to what Dr. Sahil already told, tacrolimus has a membrane stabilizing effect on the podocytes by stabilizing the actin cytoskeleton, and along with that, it also inhibits the apoptosis of podocytes. And so that majorly helps in reducing the proteinuria, and along with that, it has also been seen to reduce vasoconstriction along the afferent arteriole. So this is for the physicians. So as Dr. Sahil rightly said, apart from tacrolimus, the renin-angiotensin inhibitors, the ARBs, fluosination is the newer therapy which is available for as an antiproteinuric measure. So if there are any patients who are not tolerating tacrolimus or they have adverse effects in those, or in which I think we can combine these therapies, and then maybe we can have an answer in the future, whether to use them in combination or whether to start with one therapy first and then use them as an add-on. So next slide, Ritika. So Dr. Sahil, what are the common adverse events of both mycophenolate and tacrolimus that you see in everyday practice? And is there any particular tacrolimus level that you target in lupus patients?
So yeah, so the data is from the transplant patient itself that the tacrolimus level should be maintained between 5 to 8 in these patient, 5 to 8 levels. That is the C0 TAC levels, and the side effects mostly are the hypertension and the deranged blood sugar, that is the hyperglycemia, and sometimes they can also lead to tremors in these patients. So these are the common side effects of tacrolimus. As also the tacrolimus itself can cause a renal toxicity, as they increase the risk of hypertension as well as they increase the renal fibrosis or the interstitial fibrosis. While the MP, the most common side effect is the diarrhea and dyspepsia, which is very common, and we have to stop the drugs in many patients, or we have to decrease the doses of mycophenolate. But there are some sodium preparation of mycophenolate, which are the enteric coated, which can be used to prevent the side effect of diarrhea or the dyspepsia. And the other side effect is the myelosuppression, which is also very common with megaloblastic anemia, which can be seen, or the leukopenia, which is being associated with the mycophenolate. As well as we have to check for the cancer screening can be done if they are taking it for long, like 3 to 5 years. So yeah, so these are the side effects of the tacrolimus and the MPS.
Yes, and I think there was a recent study of patients of lupus nephritis who were on mycophenolate, and actually suggests that patients who use PPI along with mycophenolate, they had a significantly low, I think around 30 to 40% lower level drug levels of active drug levels of mycophenolate as compared to those who were not taking PPI. But I think for Indian patients, that would be very interesting to see, because a lot of our patients might be on PPI even for the mycophenolate side effects. So I think it would be interesting to see whether the drug levels vary in these patients who are on PPI. Maybe we can see that in future. Okay, thank you, Dr. Sahil. I think we can take the audience questions at the last. Ritika, we can move on to the second topic. My second topic for discussion for today is uh, regarding IBD and IBD associated arthritis and the use of anti-TNF agents, particularly adalimumab, in these conditions, regarding their efficacy, safety, and their clinical use. Uh, so, Dr. Ankit, my first question would be, is there any data regarding the prevalence of IBD and IBD associated arthritis in India, and how does it differs from the data which is available from other parts of the world?
So the evolution, if you look at the evolution of IBD, it is interesting. So in early 90s and 2000s, IBD was considered purely a disease of the West. Now, because of good access to healthcare, better hygiene, and better sanitation, IBD is highly prevalent in our country, also in Southeastern Asia in general. So currently, there are no population-based studies at least in our country, to determine the incidence and prevalence of IBD. However, studies from large centers have showed that the prevalence is around 80 per 1 lakh person. So 80 patients out of 80 people out of 1 lakh are now thought of having IBD, one form, either UC, either ulcerative colitis or Crohn's disease. And it is estimated that around 40,000 patients are newly diagnosed each year, and which contributes around 8 to 10% of world's total incidence burden. So our country is a high incidence burden in terms of IBD, and this number is predicted to be doubled till 2040. In terms of, it would be interesting if you would see that now the patient who presents to our OPD with lower GI symptoms, now it is interesting that the incidence of IBD and infectious colitis is almost all the same, almost same. And in terms of IBD associated arthritis, because the incidence is relatively low in our country, it is around 10 to 20%. Multiple studies have shown that it is 10 to 20%. However, differs from worldwide, where the incidence of IBD associated arthritis is relatively higher, which is around 20 to 30%.
Okay. And is there any particular cause, or is it change in diet, or is there any genetic factors that affect the higher prevalence of IBD in India now, or is it better detection?
I think both have contributed. Number one is the better techniques, better detection techniques. We are now much more informed about the disease, its pathogenesis. In terms of genetic data, the different centers have provided genetic data, but it is too early to say that it is only due to genetics, or only due to sanitation, or only due to better hygiene or better healthcare access. But I think that the purely difference is made. Number one is due to the physician awareness. Many more people are now aware about the disease, and number two, the better detection techniques, which are now freely available at different gastroenterology centers around our country.
Okay. And I think regarding IBD associated arthritis, if I may add one point, I think because the incidence is lower, uh, I think we need more registry based data to ascertain the exact prevalence. And there's a upcoming ankylosing spondylitis registry, which might be able to at least answer the prevalence part of the IBD associated arthritis, since peripheral disease, the peripheral arthritis is still more prevalent. The axial disease, uveitis, and the other extraarticular manifestations are even lesser than 5% in certain small cohorts from various institutes in India. But it would be interesting to see the registry data, which might be published later this year. So, Ritika, next question, please. Uh, I think this is a very general question. As an induction therapy in moderate to severe colitis, so what's your agent of choice when you choose anti-TNF agents, particularly adalimumab versus other immunosuppression therapy in ulcerative colitis, let's say moderate to active disease?
So the question with every IBD patient is only this: whether to use TNF alpha inhibitors or use a non-TNF alpha drugs. The important thing to note is that all IBD drugs, irrespective if whether it be steroids or these TNF alpha inhibitors or newer molecules like vedolizumab or ustekinumab, have a ceiling effect at 35%. So that means that the induction therapy, works only in 35% patients. And interestingly, there are no head-to-head comparisons. There are no trials which compare adalimumab to, let's say, infliximab, or adalimumab to, let's say, tofacitinib or steroid. There are only placebo-controlled trials. So as such, the choice of therapy depends on the physician. Now it is different for both ulcerative colitis and for Crohn's disease. And Crohn's disease, we follow a top-down approach. We hit the disease hard at first. So I might use adalimumab or some other TNF alpha inhibitor like infliximab in Crohn's disease in first go. However, for ulcerative colitis, I would still give a trial of steroids before switching over patient to a TNF alpha inhibitor.
Okay, Ritika, next question, please. This question is regarding the dose that you follow. Any particular regimen, any duration of use, or does it depend upon the response of the patient? So, as you mentioned, do you use loading doses of adalimumab or infliximab in your patients of moderate to severe active ulcerative colitis? And in your experience, what is the usual duration of use in these patients?
So again, the question I would answer in two aspects. One, first for ulcerative colitis and then for Crohn's disease. So there is definite trials and definite data that you have to give an induction dose. For adalimumab, I use a 160 milligram induction dose, and then I go for a 80 milligram dose every 2 weekly. Now, different data have shown different type of regimens which they use for maintenance. Like 40, some people use 40 mg weekly, some people use 80 mg 2 weekly. I use 80 mg 2 weekly just for the ease of use. In terms of adalimumab versus infliximab, so infliximab is a drug which is used IV. So it is much better to use adalimumab for patients, so because it is much easier. They can use it at their home, and there's much less chances of infusion reaction. In terms of the duration of drug which I have to give for in Crohn's disease, if patient is doing well, I'll not stop, I'll not change the drug as long as the patient is doing well. However, for ulcerative colitis, sometimes, only sometimes I might change, but the problem is that there is a loss of response for a TNF alpha inhibitor. So around 25% patient there is a loss of response, and around 30% patient they develop anti-drug antibodies. So these drugs do not work. And interestingly, all of this happens within first year. So most of the loss of response, it happens within first year, and it is up to 4 times more high. And subsequently, each year the loss of response rate decreases. So I was much happier to use continuously adalimumab as long as patient does not have any affordability issues, and patient is doing well. So I would only follow him or her clinically, and then I would like to use adalimumab. Do not stop these drugs.
Dr. Ankit, is there any data to suggest that the anti-drug antibodies that you were talking about that lead to secondary non-response in these patients? So, have they been found to be more with infliximab, with, let's say, compared to adalimumab, or with small molecules like tofacitinib? Because there are studies in, at least in rheumatoid arthritis, that say that definitely the anti-drug antibodies are highest with infliximab as compared to other anti-TNFs, and they haven't been seen in patients who are using tofacitinib till date. So, is there any similar data for patients in IBD?
I'm not aware of the data, but from my experience, I know that tofacitinib, I have not seen any anti-drug antibodies. I have seen both for infliximab and adalimumab, and yes, it is much more for infliximab and adalimumab. For these IBD patients, I also use a low dose azathioprine. And it is recommended to use low dose immunomodulator, which decreases the production of these anti-drug antibodies and which helps the patient much.
Okay, so for the physicians, one of the reasons for higher anti-drug antibodies with infliximab is because it's a chimeric molecule, as compared to adalimumab, which is a humanized monoclonal antibody. So this is just one of the reason. Although theoretically both rheumatoid arthritis and IBD are different diseases, one is more of B cell mediated, while the other is more than T cell mediated. So it would be interesting to see if similar data can be replicated in IBD patients who have a secondary non-response to biological use. So, Ritika, next slide, please. So, do you use adalimumab upfront in treatment-naive patients of either Crohn's disease or ulcerative colitis? Patients, this is for patients who are steroid responsive.
So again, as I said earlier, that for Crohn's disease patients, we follow generally a top-down therapy. So by top-down, I mean that I hit the disease hard at first, and then I start thinking about tapering the drug or tapering the dose or something like that. However, for ulcerative colitis, is simple. We use steroids first. If patient is responding to steroids, then we switch patient to immunomodulators. If it doesn't work, the immunomodulator steroid doesn't work, or patient has a steroid-dependent disease, then only I'll use adalimumab. However, for Crohn's disease, sometimes I might use TNF alpha inhibitors depending on the disease burden the patient has and the type of disease the patient has, generally B2, B3 disease or extensive disease. I would like to use TNF alpha inhibitors first as an induction therapy, even though patient it has not been introduced to any other drugs. Then I would like to use TNF alpha inhibitors. Otherwise, in ulcerative colitis, I would still use steroids. I would give a trial of steroids first to the patient.
Okay, Ritika, next question, please. So, I think you have already discussed the tapering regimen that you follow for these patients. So, have there been instances in which you are able to stop this therapy for patients of ulcerative colitis at least?
What happens is that patients sometimes stops themselves, because of the the
Got it.
affordability issue. Sometimes patient they stop themselves, and that if they are doing well, I do not restart it again.
Okay. And
Because
if restarted, do these patients regain the original disease activity at a same dose, or you need to reinduce them with the
I
loading dose?
if the duration is higher, so suppose the patient is have not come to OPD for like 6 months and now has come again, I would like to use a induction dose again, and then I would like the weekly maintenance dose. However, bi-weekly maintenance dose. However, if the patient is sometimes it depends on patient to patient basis. Patient is doing well, I would still go for a maintenance dose. The guidelines, they recommend to do a therapeutic drug monitoring and to maintain the levels between 5 to 8. But therapeutic drug monitoring is costly, number one. And on the basis of sometimes on the basis of therapeutic drug monitoring, I might decrease the dose. However, I still believe that if the patient is doing well on a dose, I generally do not, neither do I test for these therapeutic drug levels or antibodies, nor do I change the dose of these patients, both in IBD, both in ulcerative colitis and Crohn's disease.
Okay. Is there any data to suggest that addition of azathioprine might decrease anti-drug antibodies for these patients who are
Yes,
on
there is
adalimumab?
there is definitive data. A patient with TNF alpha inhibitors, if you add immunomodulators, low dose immunomodulator, you do not need to use the maintenance dose of immunomodulator that you use generally. You use only 50 mg azathioprine with adalimumab or infliximab. There is decreased incidence of anti-drug antibodies, and which is good for patient.
And I think similar data is available for patients of rheumatoid arthritis. The addition of methotrexate to adalimumab actually decreases the incidence of these anti-drug antibodies. So I think that is very important, that addition of azathioprine even at 50 OD dose might decrease anti-drug antibodies in these patients. So Ritika, next question, please. So if considering that the patients are on regular use of adalimumab without skipping their doses, what proportion of patients in clinical practice have flare on adalimumab? And is it usually a severe flare or a mild to moderate flare?
So there are a number of causes of flare in patients with IBD. You cannot, just pin down that the flare is because of the drug, or there are multiple causes like infections, uses of other drugs like NSAIDs. So we have to look at the cause of flare in IBD patients. Number one. Number two, if you'll ask me, for TNF alpha inhibitors, it's around 20% patients with flare in. It is likely due to secondary loss of response. I would not use the term flare. Patient lose the response within 1 year. If patient has not lost the response in 1 year and is doing well past 1 year, I am a relatively happy doctor to treat those patients, because I know that the chances of flare would be much less, provided patient does not have any infection, or he is, following the diet which we have advised, and is not taking NSAIDs. Then the rate of flare decreases as the year passes by. However, in first year it is around 20%.
Okay. Next question, please, Ritika. So, what are the common adverse effects of adalimumab that you have noted in IBD patients who have taken, let's say, adalimumab for a period of more than 6 months? So, are there particular infections that you might have noticed in clinical practice, and do these infections require hospitalization?
So for both TNF alpha inhibitors, they increase the risk of systemic infections, systemic reactions, and they also increase the risk of opportunistic infections. So the most important of this is tuberculosis. In India, there's high prevalence of tuberculosis, latent TB also. So after using TNF alpha inhibitor, there's increased chances of patient having reactivation of tuberculosis. So I would like to first screen for patient for latent TB. I also screen all patients I am prescribing TNF alpha inhibitors like adalimumab. I screen for latent TB first. Apart from the risk of infections, I would say deranged LFT is the number one problem that patient presents to our OPD with. Number two is cytopenias, and some patients have infusion site reaction also, which is more with infliximab than adalimumab. And some patient presents with a lupus-like syndrome. And also, I would like to point that these patients sometimes present with heart failure. So I do not use these patients who have a cardiac history. I do not use these drugs, both adalimumab and infliximab, in patients who have a cardiac history. I generally use in patients who does not have any history of malignancy, does not have any history of heart disease, and does not have any history of tuberculosis. So in these patients, I would be much happier to use a TNF alpha inhibitor. For all the three patients that I have told before, I would use a newer molecule if the patient is affordable, or something else apart from TNF alpha inhibitor. I would rather not use these drugs in these
And
patients.
are instances of CMV infection more with patients who use adalimumab, or are they similar to other patients of IBD who are on immunosuppression? Is there any data to suggest that anti-TNF therapy might increase the incidence of CMV infection in these patients?
So, if you understand the disease pathophysiology, the incidence of CMV infection occurs when the colon is diseased. So, if a patient of IBD who is already on therapy has developed a new onset CMV infection or CMV colitis, it means that the drug is not working. It is not due to adalimumab or infliximab. It is a soft marker that the drug is not working. You either have to increase the dose, or you have to look at the therapeutic drug levels or the antibody levels, with why a patient who was doing well has now developed a CMV colitis on top of the disease which he or she already has. So
Okay.
it is not due to adalimumab, but it is rather due to the disease activity the patient develops new onset CMV colitis.
I think it's a very important point, and I think it would be very helpful to a lot of physicians because sometimes it might be challenging to differentiate an IBD flare from a CMV new infection or a CMV reactivation. And as you rightly said, all patients in which we are planning to start adalimumab should be screened for latent tuberculosis. And so coming to the next question, I think it is regarding next question. So I think we have already discussed that the regular screening for latent tuberculosis is required in all Indian patients in which we are planning to initiate anti-TNF therapy. And I personally do a chest X-ray, MAN2, and TB Gold, all three, but at least TB Gold, I think, should be done in Indian patients, and even 20 to 25% of normal Indian population might be positive for IGRA. So but I think in those patients who are positive, a treatment with dual therapy, that is rifampicin and isoniazid for a period of at least 3 months, or just INH for a period of 6 months should be sufficient. And so, do you treat for latent TB for a certain period before starting adalimumab?
I would like to my method of screening for LTBI is somewhat different from yours. So guidelines recommend do a chest X-ray and the TB spot test. But however, I do not do it. I go for a CCT chest rather. It would much better pickup rate than either a Montu or a TB Gold test. So I do a CCT chest at Montu. Number one. Number two. Uh, I always treat these patients if I have some suspicion of tuberculosis, because the relative risk increases by two folds if a patient is receiving TNF alpha inhibitor. And as per the regimen, the treatment of LTBI is controversial. However, for as per Indian scenario, I would rather give a 3 month regimen of both INH and rifampicin, or a 9 month regimen of INH alone. And if the patient disease burden is high, I would start after 2 weeks. And if I can wait for 1 month or 2 months, I would rather wait for 1 month and then start the adalimumab or infliximab for these patients.
And I think it is similar to what we practice in patients of spondyloarthritis. If the disease burden is high, we start it as early as 2 weeks, or we wait usually for a month of latent TB treatment before initiating adalimumab. Just that in patients who have an NYHA class 3 or 4 dyspnea or heart failure, the guidelines do suggest that only to restrict adalimumab to those patients who have, like, we cannot use them in patients who have a definite class 3 or class 4 dyspnea, but it can still be used in patients who have one or two. But I would be very careful in using them if a patient had a previous history of clinical heart failure. I think that is a very important point to note. So,
The
next
multiple
question.
drugs in the
Yeah.
market, you cannot, subject a patient that just because guidelines suggest that patient with
Yeah,
NF2
I
is
agree
not.
with that. Yeah. Next question. In patients who have severe disease, in or those who are refractory to, let's say, you have patient who has lost response on infliximab. So would you rather switch that patient to tofacitinib or to adalimumab? Are there any trials, or if there are no trials, what is the usual clinical practice? Do you switch these patients to a second TNF first, or do you prefer to switch them to a newer molecule, let's say maybe a tofacitinib or veldolizumab? What's your take?
So it is an interesting question. So there was a recent study in for rheumatoid arthritis, I think, where they showed that tofacitinib is better than TNF alpha inhibitors for I think it was for rheumatoid arthritis Chinese study where they showed that it is better than adalimumab or infliximab. However, there are no such studies in IBD. Number one. Number two, the overall cost nowadays for adalimumab and tofacitinib, it would be, I would call it comparable, not much of a difference, and there is same risk of TB and infections with both adalimumab and tofacitinib. However, the risk of herpes reactivation and venous thrombosis, which is more with tofacitinib than with adalimumab. So, as I told earlier, the patient does not have a history of malignancy, does not have a history of heart failure, does not have a history of TB. I would much rather use adalimumab than tofacitinib because the data for adalimumab is much more extensive. However, as you said, that if patient previously has taken infliximab or some other drug, anti-TNF experienced patients, anti-TNF alpha inhibitors experienced patient, I would use tofacitinib than adalimumab for such patients.
Okay. Next question, please. So just a question from my side. So there was a trial in patients of rheumatoid arthritis which said that the 10 milligrams BD dose of tofacitinib actually increases the risk of having venous thromboembolism and the carcinogenic risk, as well as herpes reactivation, as you said. So like in clinical practice, does that hold true that the 10 milligram BD dose has a higher risk of infections and cardiac events in those with comorbidities? Have you found the same, or is it just restricted to the data?
In only two patients who are on tofacitinib who develop venous thrombosis. However, I have seen many patients who have developed herpes zoster infection. So I cannot say, I do not know about the data, about the Indian data, whether this holds true or not. However, as per my experience, I have seen patients who have developed venous thrombosis on tofacitinib and also herpes zoster infection, but much less incidence of venous thrombosis than herpes zoster.
Okay, and I think for the physicians, if you are planning to initiate these patients on tofacitinib, maybe you can vaccinate them with the recombinant herpes zoster vaccine if it is available in India, and if possible, these patients, especially those who are age more than 50 and those who have comorbidities, they can be easily vaccinated with vaccines. So I think thank you, Dr. Ankit and Dr. Sahil, for the excellent discussion on both the topics. Ritika, if there are any questions, you can take them from the audience.
Let me just check, ma'am. I can see, ma'am, few questions are there. So I'll just put forward one or two. Like one question is there, how long should MMF be continued in patients with history of lupus nephritis to prevent relapse?
So the data says that it should be given for almost like 3 to 5 years. Once we have achieved the remission, then it should be continued for 3 years to 5 years. There is some data that in patients having lupus nephritis, we can do a protocol biopsies to see for any disease activity. So if there is disease activity, we have to continue the treatment, or we can decrease the dose of MMF by monitoring their urine routines and the creatinine levels.
Yes, I think Dr. Sahil has discussed. I think in a patient who has achieved remission or at least a partial response, not remission, uh, patients can be continued on maintenance MMF for at least for a period of 3 to 5 years. That's what the guidelines say. Although I would emphasize that in clinical practice, it's not the deadline that you have to stop therapy at 5 years. There are patients of lupus nephritis who continue MMF much beyond 5 years, but the guidelines suggest that the patients who have achieved a partial renal remission, at least a partial renal remission, should be continued on maintenance MMF or azathioprine for a period of 3 to 5 years, and provided they have received induction therapy for a period of at least 6 months. So that is the guideline.
One more question, madam. We'd like to frame what I've received is, how often should patients with IBD-associated arthritis be monitored for response to adalimumab? And what are the key indicators of treatment effectiveness?
So there are no guidelines per se for patients of IBD-associated arthritis. So we usually extrapolate the guidelines of spondyloarthritis to these patients. So it would actually depend upon the involvement, the joint involvement. If it's an axial or it's a peripheral of, or it's a combination of both. But to say whether the patient is not responding to anti-TNF therapy, we need a period of at least of 3 months of therapy, that to a regular dose. We don't use the loading dose for arthritis patients. So the usual dose for Adali is 40 mg every 15 days. They have been given at 40 mg weekly also in few patients who have not responded, but the usual dosing is 40 mg every 2 weekly. And we the follow-up would depend upon the physician. There's no certain guideline. But to say whether or not the patient is responding, you need at least 3 months of therapy with anti-TNF to say that the patient is responding or not responding. So,
Right.
and this is along with the NSAIDs, if allowed, and other therapies such as methotrexate or maybe sulfasalazine that these patients might be taking for IBD or for the arthritis. So I would say I would like to see them maybe every month or every 6 weeks, but the response would be at 3 months at least.
I would
Right.
like to add one point. NSAID should not be used if the patient has active disease or inactive disease. Rather, a patient with IBD should not use NSAIDs because it is one of the most common, one of the most common factor which increases the disease activity. So we should not use NSAIDs. Rather, we would be much happier if the rheumatologist use a methotrexate or some other.
Recommended is you should not. Right. Right. So I think that's it for now, because rest if questions are there, definitely we can just communicate to you and you can answer it in the comment box. Okay. I think that's okay for now. And on the concludatory note, I would like to thank Dr. Kriti, Dr. Ankit, and Dr. Sahil. It was a great interaction, very informative session, and whatever insights you have provided, that is like you have kept in view of the real world settings, what experience you had and how you are dealing, so that as a marketer we also got really good insights with such a fruitful discussion. And thank you for your valuable insights and your timing you're given to us, and for making this session a great success. Thank you, sir. Thank you, ma'am.
Thank you.
Thank
Thank you.
So